Today, I'd like to talk with you a bit informally about some of the tips from the field that we can share with you. I know you have a lot of tips you also share with people your colleagues who you're working with. So let me give you the benefit of our experiences, and I encourage you all also to share with us any experiences you have with similar types of costing of illness. This is all going to be based on our use of the CETA or SETA, whichever you prefer, cost of illness tool when we were in Ethiopia and Ghana using this tool. Talk to you a little bit about the preparation that we did for the cost of illness study. We made work plans. We found that it was really useful for us to prepare a schedule of all the tasks and assignments that we had for each other. We made sure that we assigned those tasks to individuals so that the team members of our costing team, we knew who they were, we knew who was supposed to be doing what, and we wanted to make sure that everyone was included in the work that we were going to be doing. And to do that, we had a work plan template, which you may or might not find useful. I'm just showing you a screenshot of it right now. I call it our INTS cost of illness costing team work plan, where we have goals that we put up. And when you go to the goals, that's going to take you to tasks that each person needs to do, when it's started, when it's due, and also what its current progress is and any notes. So you can download that from the folder that I showed you before at the beginning of this talk. You might find it useful. I hope you do. These team members, you can change their names at the beginning of the work plan so everyone knows who's supposed to be doing what. And in this INTS cost of illness costing team work plan, I've also put in almost 70 of the different tasks that we needed to do to complete our cost of illness work. Hopefully you'll find those useful as well. As we go through all of these touch points, I welcome you to ask questions and to also raise your hand if you have a question and break in. I know someone's just asked, is the latest version of the tool version 7.0? And it's not, it's 7.1. We did a little bit of tweaking yesterday for you there. And so as I said before, that would be available in the folder that we told you is on bit.ly/INTS_file_folder. So you can find it there. The other thing that we found useful and we recommend to you is holding weekly touchpoint meetings, both internally and also including IVI. And if you have an external consultant working with you, making sure that you keep everyone up to date on what progress is. We also encourage you, if you think you're going to need help, to include me, the tool developer, in the meetings so that you can get answers to any questions you have about using the tool more quickly. Just to reach out to me and say, we'd like to include you in this meeting and be glad to help you. Sometimes the tool can be a little confusing, and sometimes you might have a difficulty with it. So I wanted to let you know that we're there. I'm going to bring the microphone a little closer because people say that I'm breaking up. Let me know if you can hear me better now.
Yes, now it's better. Thank you.
Okay, great. Thank you. We also want to, when we were working on we visited the clinics and the hospitals. So when we were getting ready to visit the clinics and the hospitals, we made sure that we didn't try to do too much in one day. when we tried to visit a clinic in the morning and a hospital in the afternoon, we found that often we were rushing our interviews. So we encourage you to take time for your field visits. Think about how much time you're going to take to do it, and then double that time to make sure that all the things that happen when you're traveling or when you're getting people together don't make you rush too much when you're actually doing your interviews. Also, make sure that you, I'm sure you know this, to brief the chief medical officer of the hospital and a health clinic manager about your visit, what the purpose, and what you're trying to get in terms of data. Because sometimes they have to go back to their records or get their records administrator to put things together for you. And that helped us a lot with the data gathering. When we asked them ahead of time, when we could visit, made sure that they knew why we were visiting and what we needed to get from them. I don't know what it's going to be like in your situation, but we found that there really was only one hospital in each area that was managing the severe cases in Ghana and in Ethiopia. So we found that it was better for us to visit more than we would have liked to visit more than one health clinic when we went out, certainly to Ethiopia and also in Ghana. So we recommend that you take a look at who's actually treating the severe cases. And if it's just one hospital, make sure that you spend a lot of time in that hospital, and also try to visit more than one clinic so that you can get an average of costing, and also make sure that what one clinic is doing for non-severe cases, the other one is doing as well. Or if not, that you can get an average or a variety. One of the things I can tell you, we didn't pre-test the case type definitions or the procedure definitions or the equipment set definitions before we started data gathering. And if we had it all to do it over again, we would pre-test the case type definitions. As you know, that there were case types of under 5 years old and over 5 years old. There were also confirmed, non-confirmed, and then the case types were also divided into non-severe, outpatient, then severe inpatient without surgical, and then we had 3 types of surgical, invasive surgery case types or definitions that we used. And we found that we needed to spend some time with the people we were interviewing to help them to understand how we were looking at the cases, and also the procedures that we thought they were using. And as I said, if I were to do it over again, I would want to look at what procedures, how they defined their procedures they were using, how they were defining the case types that they were seeing with typhoid and with INTS, so that we could modify our interviews to make sure that we were talking in the same language. So think about pre-testing these with the department heads and with your district medical officer if you're working in a district, to make sure that those definitions are at least compatible with the definitions that people are using in the field. Some ideas about checking setup data. When you are putting the place in the tool, it says you can put in a country, you can put in a province, you can put in a state if you want to. We found that it helps if you limit the place name that you're using to the location of the study area. So people understand when they start reading your results that the results are valid and reliable only for the study area itself, rather than the whole country that you're working in. Some people ask me about the scenario, that we have a place where you type in your scenario name. We're trying to do with that is encourage people to save the tool often. And when they do, to use a scenario label so that you know which version of the file that you're working with. So we have like, this is the baseline scenario, version 1, baseline scenario, version 2, baseline, draft 3. We use the scenario to name the files that way and hope that you can do the same, and hope that will help you. Now, of course, everyone's doing a retrospective study in this case, but you can do a cost projection study, and it's going to be fairly easy to do that later on. So keep that in mind when you are filling in your data, that you will be able to do a cost projection based on the cost that you collected in the retrospective costing. All you really need to do to change to a cost projection is just use different numbers of each case type. And the tool can lead you through that. I can show that to you as well if you want to see that as we move forward through this. When you're working on your currency exchange rates, remember that the international currency we're using is always US dollars. Use your local currency, and when you're setting up an exchange rate, make sure that you use it for the year that the data is covering. So if you're getting data from 2021, use an exchange rate between the local currency and US dollar for 2021, the year that you will have that we will have been expending the resources. Also, I found that in the exchange rate, that the best exchange rate source I found was the United Nations. The United Nations has exchange rates. You can just look UN exchange rates. They have historical exchange rates that are comparable across many studies that people do. So I'd recommend that to you, to use the exchange rates. Go ahead, please. I'm sorry, what? I didn't hear that. Okay.
This may not be a question.
Okay.
But I mean, Win, just since we're in a pause, your voice is still a bit breaking up. So
Oh, it's still a bit?
Yeah, it's I don't know. It didn't happen before, right? Between you and me, but
no, I'm not sure what's happening. I mean, I've got the microphone right up to my.
Now it's crystal clear.
Okay. Well,
Yeah.
I'll stay here.
I think Pepe has a question. So Pepe,
yeah.
Yeah, about the exchange rate. For us in DRC, actually we have a devaluation of money, so we have not the same exchange rate before the beginning of the year till now. So what we have to do in this case?
Yeah. Well, my recommendation to you would be to look at the UN exchange rates, and they have it for each month of the year, or usually at least every 3 months of the year. So whenever you were spending that money, I would look for an average exchange rate within that period that you were spending the money, and use that exchange rate. Also, the good thing is that when you are putting in your exchange rate in the tool, there's a notes and sources of information. And my recommendation would be that you make a note of, first of all, your source of the exchange rate, if you're using the UN exchange rate, and also the month and the year that that's coming from.
Okay.
I'd like to talk with you a bit about case definitions. Remember, I'd said that you should review the case definitions with a senior hospital clinician or a district medical officer. I'm wondering, when people were looking at the case type definitions, if anyone here had any questions about them or any concerns about the case type definitions that we're using here. I'm not hearing anything, but I am going to say that when we were working with the patient age, the patient age range type, when we were in Ghana, when we were in Ethiopia, it was very difficult for us to separate between under fives and over fives. When people were telling us about what procedures they were using, they used the procedures for pediatric doses and adult doses. So what I'm recommending, and you can see I've put in here and in the latest version of the tool, is that you use the terms of pediatric cases versus adult cases, because that's when you're going to get a significant difference between the costs of the procedures. So I'm just making that note. The other thing that you will find, I think, when you're working on this is confirmed versus unconfirmed cases. That it may be difficult for you to find whether a case was confirmed or unconfirmed. So be mindful of that when you're doing your case counts.
Can I ask you a question, Win?
Yeah, sure.
So in your previous slide, when you talked about this patient age range, I mean, I understand your point, why the distinction between pediatric and adult would be useful. At the same time, this outcome will have to be combined with patient level out-of-pocket surveys that we've been conducting. I mean, all teams here, they have been conducting this study. At some point, there must be a threshold that distinguish the two. So maybe, do you think it would be useful to add a certain age threshold to distinguish between pediatric and adult, say 5 years old?
Yeah, we could do that. That sounds like a great idea, as a matter of fact. So we could say pediatric would be under 5 years old, and then adult would be over 5 years old.
Sure, that sounds great to me. I guess I hope that this is clear to everybody here for INTS as well as typhoid regarding this age range type. So under 5 and over 5.
Yeah, one of the things I think you're going to find, I'm going to talk about this briefly later, but when you start looking at the number of cases that were recorded, at least in Ghana and Ethiopia, we're talking about fewer than 10 cases. So what we found is that it was much more useful for us to concentrate on getting good data on the cost of the procedures for each type of case type, because later on what we did was we changed to a cost projection where we projected that there would be many more cases, so that we could look at what we thought the actual cost was going to be if you had more cases. The other thing that happened in Ghana and Ethiopia was that we measured the numbers of cases after there had been a significant vaccination campaign. And so because there had been vaccination, there were much fewer cases than there had been previously. So don't be surprised if when you start asking how many cases were there, that there may be very few to work with. And focus again on the costing of the different types of procedures. You'll see here that I still have, this is from an old slide, 3 years plus and under 3, but I changed this to pediatric and adult in the latest file. But then you'll notice that we have on our procedures outpatient comprehensive exam, and that's usually going to be happening in the clinics that don't take inpatients. And then inpatient intake is going to be reserved for hospitals. The other thing that we found a little bit of difficulty with was determining how many of the cases got second-line antimicrobials as well as first-line antimicrobials. And so we found that what we needed to do was, since fortunately there were so few cases, that we actually got the case records out to see what the prescriptions were on the particular cases that we were reviewing, to find out, hey, did they get first-line antimicrobials before they got second-line antimicrobials? And was that the way that people usually did the treatment? When we did our equipment set definitions, these are the ones that we found the most useful: outpatient department, laboratory, basic inpatient department equipment, radiology, and surgery. Radiology, because radiology often did the chest x-rays, and they were also doing most of the other internal testing other than laboratory. So that was where most of the equipment was. And then laboratory was interesting. While there's a lot of equipment in laboratory, we found that at least with SETA, with typhoid, that the only things that they really were using for equipment was centrifuges. In the end, just so you know, we decided to remove the equipment portion of the costing because it was so difficult for us to collect the surgical department equipment and also to determine what percentage of the equipment was, the percentage of the time the equipment was used for typhoid or INTS related cases. So I would say do your best to collect the equipment information. And then after we've done that, we'll take a look at whether we got enough data and valid and reliable data to include that in our ultimate review and analysis. As I said before, with the number of cases, it was very small. So I went back to the SETA COI data that I'd received a couple of years ago. And at that point, you can see the diagnosis where there was INTS in Burkina Faso. Not a single INTS case had been recorded at that time by IVI. And in Agogo, we had one. In Kumasi, we had 3 for our health facility. I'm just to send this question back to you all. In Nigeria or in DRC or in Burkina Faso, are you aware of there being INTS cases that have been defined, or I guess really in Nigeria, it would be typhoid cases that have been diagnosed through the SETA program?
So for INTS, INTS study is being done in 3 countries: Burkina Faso, Ghana, and Malawi at the moment. For DRC and Nigeria, the main focus is typhoid. Although in Nigeria, we also have this tick box for INTS confirmation. But in DRC, I mean, what's known is that there are a lot of INTS cases, but for now, INTS is not included as a part of this typhoid study.
Mm-hmm.
But in Burkina Faso and Ghana, as you pointed out, I know this table is from the previous SETA COI data. We are experiencing something similar. We have a low case enrollment for INTS in these 2 countries, Burkina Faso and Ghana. So far, we have about 4 or 3 cases.
Mhm. Okay, so as I said, then that confirms what happened with us. So you can expect to see only a few cases. So don't let that disturb you when you're doing your cost of illness study. Also, when you make sure if you can get access to the facility records, take a look at the facility records and see if it's possible that there are other cases that may have, as we say in America, fallen through the cracks, may not have been reported anywhere else. Try to look within a 12-month period when you're doing your count. And also when you're looking at the case file, since you're only going to have a few cases, see if you can classify those cases as fully sensitive or multi-drug resistant. And I think the best way to do that would be to see if in the case they tried the first line antimicrobials, and if it worked, then that would be fully sensitive. And if it didn't, and they went to multi-drug resistant, then you could classify that as multi-drug resistant. So when you're doing your record reviews, this is us in Ethiopia. You can see that everyone is going through the records, and you can see that we didn't do it ourselves, but we encouraged the clinicians who we were working with to go through the records and then to share those with us, so that they took ownership of the actual study that was going on. We want to make sure that when we're doing these studies, that not only we get information and experience from this, but also those people from whom we're getting the information also get that. So here you can see we're in a clinic in Ethiopia. Everybody's gotten all the records out for the different typhoid cases they've had over the years, and they're reviewing it with us. We did a lot of interviewing, both in the clinics and in the hospitals. This is in Ethiopia. We tried to keep it as informal as possible, so that when we were doing interviews, we were not doing a fully structured interview. So when you see our files and our data collection, there will be notes about what kind of information we're trying to collect, but we did not go through a fully structured interview of asking questions. We more used a semi-structured interview where we knew what kind of information we were trying to get, and we shared that at the beginning. But also, we made sure that we involved the clinicians and had them, as much as possible, tell the stories of what it was like diagnosing, finding, and treating people with typhoid. Another thing we found really useful, like in the outpatient and the laboratory, is photographs. With the permission of our hosts, we tried to take photographs of the laboratory, the outpatient departments, the inpatient facilities, the radiology. So what we were trying to do is document, for those people who hadn't seen these places, exactly what kind of environment we were working in and we are talking about when we're doing this costing. Otherwise, a lot of people who have not been familiar with the type of environment we're working in may get a very different idea of what a hospital looks like or what a health facility looks like. So we encourage you to take photographs as much as possible. And while you're doing that, we encourage you to take photographs without you in it, or without the interviewers in it, as much as possible, so that the people who we are focused on when we're doing the cost of illness are not the researchers, but the people who are being interviewed and providing us with our information. We'd also like to encourage you and tell you what we did. Every day after we did interviews, we sat down together for an hour or two and reviewed our notes that each of us had taken. You can see that some of us had just informal notes. Some of us were using the forms that you can see in the middle of the table. Other people were entering data directly into the tool. So we got together after the interviews each day and we shared our information. We had one person who was in charge of a master copy of the tool. That person put in the data that we all agreed should go in after we'd all compared our notes. Those of you who've been looking at the tool know that one of the main parts of gathering the data is going to be getting unit costs or unit prices. And so here are some of the things that might help you as you're working on collecting this data. Personnel costs or salaries is always going to be a little it's going to be a little intimidating for people who have that information to give to you. So if you use, a lot of it's going to depend upon the terms that you use when you try to get the salary cost for the different cadres or categories of people. So we found that using salary grades or salary scales, rather than tell me what their salaries are, that met with less resistance. People were more willing to share the information. Often also, if there is a published salary scale, it's good to ask for that. And usually that has the cadres of the health workers as well on that. Because of the nature of the costing that you're doing, not a lot of travel and allowances were used. So while that's in the tool, we found that we didn't use that much. The one that we did use a lot was the drugs and medical supplies. And we found that going to the government medical stores, either the central one or the regional or state or provincial one, that they usually had an internal price list for the drugs and the medical supplies that they're using. We found that absolutely useful for us to get the unit prices. Also, we found that some hospitals that we went to had an internal price list, but some of the times it was, you have to be careful. Sometimes it's what they charge the patient rather than what they purchase from the medical stores. So make sure that when you're looking at the price list that you get, that you know who's being charged for it, whether that's the internal charge or the charge to the patient. You want the internal charge. We didn't use the other supplies very much. That's one of the possible uses. You say other supplies other than medical and drug supplies. You might find that you have a use for it. We tried to keep to drugs and medical supplies and then other direct costs. And then what the other direct costs, when we're putting that in, we're using that for laboratory tests and for hospital bed days. Because when we tried to break down all the items and units that were required for a laboratory test, we found out that to be almost impossible for us to do. Because you have these reagents, you have this equipment, you have that equipment. So what we did is we went to the hospital administrator or to the administrator in the health clinic, and we got from them the average cost of doing a laboratory test. So instead of doing an individual itemized detailed costing for laboratory tests, we just plugged in a number for that. Usually those costs are not really high, so that's not a big cost driver for these costings. So that's how we handle it. We'll leave it to you how you want to handle it. Again, we found getting an equipment list, the costing, and trying to get the percentage of time for which the different pieces of equipment were used for typhoid related cases or INTS. That was really problematic And the reason for that is that if you've got all this equipment, but you have one case of INTS, then it's almost impossible to say what percentage of the time the equipment was used for this one case or these three cases. So, when you're dealing with this small number of cases, it's going to be very difficult, I think, for us to include the cost of equipment. If, however, you're going to be doing a cost projection later on, if you say, okay, well, what if you had 200 cases of typhoid or 200 cases of INTS, you could ask a hypothetical question to people who are in those departments to say, what kind of value or what kind of stress would that put on the equipment that you have there?
Win, thanks. Just quick question. Equipment costing section is still available in the current tool, right?
It's still available, yes. Mm-hmm.
Okay. Yeah, but I fully understand it would be difficult if there are only a few cases available. But yeah, I guess we will see. Because number of cases is also variable across the countries. So maybe some countries should be able to fill in equipment cost, but probably the others with fewer cases, this may not be feasible.
Yeah, the whole problem, Jung-Suk, is really going to be with the percentage of usage, with such a small number of cases.
Right.
And I think what's going to happen is that when we do our final analysis, that we're going to have to make some assumptions on that. And that's probably going to be post data collection.
Sure.
Here's a couple of tips when you're doing your standard procedures. All right. When we first did this cost of illness study, we decided we were going to have the best practice, and then we were going to have the common practice. So the best practice would be these standard treatment guidelines. For example, both Ethiopia and Ghana have standard treatment guidelines for treating different types of typhoid, and I guess INTS as well. So we found those really helpful when we were talking with clinicians about the types of treatments and procedures they were doing. Because if they left out part of that procedure, we might ask them, well, did you do this? Did you do that? Particularly when it came to doing Widal tests. A lot of people were still doing Widal tests when they really aren't recommended anymore. But if that's something that they're doing on a regular basis, it's good to know. Also, the malaria tests, and I don't think at that point anybody was doing HIV tests, but it might be useful, I think, in the case of INTS, both malaria and the HIV tests. So standard treatment guidelines are good to pick up as a reference, but we realized that we couldn't do a costing on best practice and common practice. Rather, we just did a common practice costing. So cost what people are doing, don't cost what they're supposed to do. We also wanted to share with you the way that we went about getting the procedure information. And what we used we called it a service journey story. So you see people here, they're having a fun time. And one of the reasons they're having a fun time is that they're telling us a story and we're telling a story back to them. So to do a service journey story, we first will describe the case to a group of clinicians. So we'll say, okay, you've got a person under 5 years old. They present with this step fever. They present with diarrhea and vomiting, and their fever is getting higher and higher. They look dehydrated. So what do you do about that? Take us through from the time that they enter the door until the time you're finished treating them. And so they would tell us in detail exactly what procedures they do, who they do it with, what they're doing. And then after they had told that story to us, we retold it to them. So as we were retelling the story, we would encourage them to correct us. Oh, what did I forget? What am I saying wrong? And what happened, which was I thought was great, is that usually when the story was initially being told, there were one or two people who would tell the initial story about what happens in the clinic, what happens to the inpatient, what happens in the hospital bed, what happens in surgery. But as we retold the study, and we call it, this is our understanding, everyone else in the room would chime in and come in and say, no, that's not exactly what happens. Or they would say, oh, don't forget, we also could have used this drug. Sometimes we did this, sometimes we did that. So as we retold the story, we started getting a very full picture of not only the regular routine procedure that people do for a case, but also variations on it. Also, as we were retelling the story, we would ask detailed questions. We'd say, okay, what drugs did you use? What medical supplies did you use? What equipment did you need to do this? And so we were encouraging all the participants to discuss among themselves if we were completely correct with our storytelling. And as I said, they were often corrections, and people had fun pointing out that this is different and that was different. But we found it very useful as a way of collecting information about the actual procedure. And I think that they found it was a lot of fun doing it as well. And so once we had agreement on the stories, then we would take the group into the OPD or to the lab or the surgery, and we would actually act out the stories. We would have someone be the child, or we would have someone be the laboratory technician. We would have someone be the clinician, and they would role play going through each of these procedures. And as they're doing it, they'd recall the times that they'd done this before. And it was really, again, was both entertaining and educational, I think, for everyone. And we use these stories not only for the procedures, but also for filling out our master price list items, because we found that some of the things that we should have listed weren't there. So we added things. And all in all, that was a great way for us to collect the data without it being too difficult or, as I'd say, boring. A bit about data input. We had data inputs. When we had the input, we involved everyone in the costing team who had been out interviewing, and also anyone who was our advisors. So as I said, we kept one master copy of the tool, and we designated one person the power user. That person was responsible for controlling and doing all the data input. Now, everyone else could also put in data into their own copy of the tool, but there was only one master, one power user. The other thing that we did, I think was really important, is we kept flash drives for every one of the costing team members. And at the end of each of the data input sessions, we shared that master copy as well as any other information we collected with everyone. So everyone felt like they had the data that they needed to be able to participate fully in the costing exercise. In this particular tool, and you'll see the latest version, I've also added what's called a data verification worksheet, and it's at the beginning of the tool. And what this does is it has every single piece of input that you're supposed to have on the cost of illness study. And it tells you in one column here what the current input is. And then we have what's called a verification column, so that if the person who is in charge or the PI for the cost of illness study then looks at the input and says, yes, this is correct, this is verified, they can then click on that each of those cells and say, yes, that's right. And so this is a good way of knowing what data you don't have, what data you do have, but it's not verified, and what data you have that's verified. Expect to have data gaps. Like every field work, you're going to have data gaps. And we found that what's really useful is you make sure that you make one person for each of the data gaps that you have responsible for following up on that and filling that data gap. We found that weekly touch point meetings kept us maintaining the momentum of the study rather than just saying, okay, email when you're done. Also, if you're going to be asking for data and you're not getting the information that you want in a follow-up via email, we found that if we drafted emails for supervisors or senior officials to send out, unless we had a strong relation with a potential source, if we had the senior officials send it out, that it got a better and quicker response than if we just kept sending out requests for data. And make sure if you ask the source for data that's missing that you copy their supervisor so that everyone's in the loop. Okay. And make sure you send thank you notes whenever you've had an interview or whenever you've gotten data. Please make sure that you do that. So that's some tips from the field. I'm going to end now, and I'm going to open this up for any questions that you might have. I'm also going to start opening up the Excel file if any of you have specific questions about the Excel file. Over to you, everyone.
Great, thank you very much, Win. It's really informative, especially slides that you created based on your previous experience with our team. I think that's really useful. Just to everyone, regarding Excel tool specific descriptions, Win already uploaded a couple of videos. So how to enter data in each step. It's all uploaded online. So I'm pretty sure many of you have already seen them, but if you have not, please take a look because that's going to be really practical. It will teach you how to enter data. So, and for the rest of our session, as Lynn mentioned, if you have any questions, please feel free to ask. Thank you. Sure, Kofi, please.
Yes, when I just want to seek for clarification. Now, once we look at the protocol and the target group as indicated in the video, the protocol, meaning that for we are looking at less than 5 years and 5 years and above. But when you look at the data input, you can see that there too is less than 3 years and 3 years and above. And I'm confused in terms of these two different target groups. So if you can throw more light on that.
Okay, thank you for that. And the reason for that is that I too was confused. Here's a situation that we have. When you look at and I'm sure, doctors, you know that when we look at the INTS, you look at the epidemiology of INTS, that it affects children who are under 3 years old the most, as well as much older people, as well as people who are HIV positive. Yes? And so at first I thought, since that when we were working in typhoid and we were working with the 5 and over group and then the under 5 group, that we should change that to under 3 group and 3+ group, Yes. Because then what we would be doing, we'd be following the epidemiology. Yeah. But then as I thought more about it, I thought, well, when people are treating their patients, they treat them according to guidelines for pediatric and adults. Yeah. And so I thought, well, maybe it would be better if we change that case to the case description to pediatric and adult. And as you know, we just had that discussion where we said, okay, well, it's great to have pediatric and adult, but we really should put an age range on it. And so, as you can see, then I think the best thing for us to do in this case would be to have, and hopefully, can you see my screen now where I'm on the Excel sheet?
Yes.
Okay, so I'm down here now going to the case types. I think what we should have is 5 years plus. And then, 5 years plus for the so-called adults and under 5 years. That's my best guess at it. I'm not a physician. So if there are physicians here who would like to comment on this, I would greatly appreciate your input on this.
Win, so I'm not a physician, but like as far as I understand, so this age range could be changed upon the practices that are made at the site, which could
Correct, yes.
differ across different sites, right? Is that right?
Yes, they can be. If you do one version for a health clinic and then another version for the for like a hospital, yes, it would be different copies of the tool, yes, but you could definitely change it.
Okay.
I guess nonetheless, because this is going to be a multi-country study, including 3 different countries, would it be good to have a certain criteria? So, Kofi, would this sound okay to you if we put it as Win just typed, under 5 years and over 5 years? Does it?
Yes, yeah, that's okay, because that is the situation we have in Ghana. If you look at our chart, normally we look at it from under 5 years, then from 5 years and above. So I think that will suit perfectly for our system here.
Sure. I think this sounds good to me as well, because I mean, not specifically for INTS, but any sort of infectious diseases, we normally, I mean, the age cut is generally less than 5, greater than 5. If we add one more, it's going to be less than 15 and over 15. So I think the current criteria, one for less than 5, the other for older than 5, sounds good to me.
Very good. Thank you. The other question I had was regarding confirmation and non-confirmation or unconfirmed. Do we have data, or do you think we're going to have data available to know whether the case was confirmed or not confirmed for INTS?
These are all confirmed.
They're all unconfirmed or confirmed, did you say?
Confirmed.
Confirmed, okay.
Yes.
I'm going to assume that if we have the situation where we are talking with the hospitals as well, and they have other cases of INTS, which may or may not be confirmed, that we can then classify them as needed. Yeah.
Sure.
So, Win, if I may ask one more question. So regarding this confirmation type, so I understood what you just explained, but then, so if it's the case where a patient are is having like clinical manifestations or symptoms which look like INTS, but when it is missing the blood test results or other like this kind of confirmation, so that could be like counted as unconfirmed INTS. Is that what you mean?
Yes, that's correct. And that is coming from directly from our work on typhoid. And when we had this discussion about typhoid, we agreed that a surgeon's declaration was needed if there was an absence of a blood test or tissue histology. We didn't say it was a clinician's declaration. We said it needed to be a surgeon declaration. And so that, of course, would only happen if there was surgery involved. So others would be unconfirmed.
Okay, but like, I'm just wondering, like in practice, like, can we say if it's INTS, like invasive non-typhoid or salmonella, when there is no confirmation, such as blood test? Because like as far as I understand, like there should be some kind of like confirmation for the serotypes that it's non-typhoid or salmonella rather than typhoid or salmonella.
Yeah, you're right. There should be. I'd like to hear what other people will think about that.
Yeah, because I'm not like familiar with those sites practices.
Yes.
Yeah.
One thing is when we use this tool, we will look for costs associated with INTS confirmed patients who are already enrolled into our patient level survey. So as long as you're there for our patient level surveys, we only enroll confirmed INTS cases.
Yeah, okay.
Like, because what we found in Ethiopia, and this is just in Ethiopia, was that there were more cases than there were patients enrolled. So in the cases of the patients who had been enrolled, of course, they were getting the blood tests for typhoid. And so there were serotypes that were declared. But then also there were people coming into the health clinics, not the hospitals, who then were declared as having typhoid, but there was no confirmation by blood test.
Sure. And one addition is for the previous CETA study, we had this criteria called complications, such as intestinal perforation.
Right.
So although our inclusion criteria for S type B and S paratype B, as well as INTS, were based on confirmation, these complicated cases, such as intestinal perforation, was not confirmed. It was basically clinically confirmed cases. So
Okay.
one of the reasons why we had confirmed and unconfirmed.
Good. Okay.
Changsor, I think also from the intestinal perforation, we used to take a sample of the fluids, peritoneal fluids, for the culture in order to isolate also the non-typhoid and the NTS. So for me, for being able to say that a case is confirmed, we need at least to isolate the NTS, either in blood or in the peritoneal fluid for the intestinal perforation.
For INTS?
Yes, INTS. But here I can see, or in the confirmed case, it's mentioned here the surgeon declaration. So I think here it will be great if we can have more clarification on that. Surgeon declaration, yes.
Sure. I think this notes section can be updated. I suppose this is also from the previous CETA study partly. But this can be modified following our INTS protocol.
Yeah, it seems to me that definitely there should be, that when you have your meetings and you're continuing the data collection, that as we get a better idea of how cases were being confirmed or not confirmed for INTS, that we keep notes on what that is.
Okay.
Yeah, I think the other thing I wanted to find out is, are we going to do retrospective or prospective? And if you are going to do retrospective, is it that it will be in 2022, 2022, from which month to which month?
Yes, well, we're going to be doing retrospective, definitely. My question to you is, well, I guess I don't know how to answer the question of what years are going to be covered, because I'm not familiar enough with the protocols. So perhaps, Jung-Suk, could you suggest what the dates should be for the retrospective study?
Sure. As we mentioned, this is going to be a retrospective data collection. Because it's going to be a retrospective data collection, it's highly dependent upon when we actually enrolled INTS confirmed cases for example, our patient level surveys. In Ghana, as far as I remember, we have enrolled 3 patients so far. There were total 5, but 2 were lost follow-up. So there are 3 cases enrolled so far. So I guess, we need to check when these 3 patients were enrolled into our study, and we follow the period. Does it make sense?
Yeah.
I think but I do think it's very important that we make sure that we're agreeing on what those dates are. And this is set up for a 12-month period, any 12-month period. Also, I want to make sure that I'm clear about the definitions I use. And with all due respect, I understand that you all know more than I do about a lot of this stuff. But when I talk about retrospective case studies versus cost projection versus progression, retrospective and prospective studies, the way I think of it is this: there's 3 types. When I think of a retrospective study, what I mean is we're looking at activities that have already been done in the past, and so those are in the past. So we're just making a record and doing analysis that way. When I think about a prospective study, that means that we are collecting the data as it happens during a particular time period. Usually that takes a long time, because if you're doing a year's prospective study, then what you're doing is you're collecting information as it happens over a period of a year. When you're doing a cost projection, and this is, again, my definitions for this, a cost projection means that you are taking retrospective information or data that you've had, and you are applying a projected number of cases to those costs. So, for example, if I were to look at the case counts here, I would have all the information already. Let me just make this bigger. In this case, if I were doing a retrospective, I would say these are the number of cases. But if I were doing it as a prospective case study, then what I would do is I'd say, okay, well, this is the number of cases that we're going to assume that we have, right? Let me get here, right here, okay? And so basically what this is doing here is you're projecting the number of cases you're going to have, rather than saying that these cases already happened. But at this point, we're really working on a retrospective costing. I'm assuming that everyone has had a chance to look at this tool. Is that correct? Is there anyone who's not familiar with the tool at this point? Good. It's good to know that everyone's seen it.
Yeah.
I'm just going to show you one of the things that I added that you may not have seen already, that I'd mentioned before. When you go to any of these pages, the setup pages of the case counts now, or these others, you'll now see that there is something called a verification sheet here that you can click on. And when you click on that verification sheet, this is what I talked about, that you've got all the input names here. And then you have the current input for all of them. And this is where you can review and say, yes, I verified that, or no, I haven't verified that, right? And so this will allow you to go directly to the place in the tool where you want to go to make sure that you can change things if you need to. That's just a little helpful thing for you to have.
Okay.
Any other questions?
Hi.
Go ahead, please.
Yeah, I have one question. So we are including all those direct medical costs from the hospital or the site, wherever. What about the direct non-medical costs that the hospital bear when the patient is hospitalized?
Are you talking about indirect costs?
No, not the indirect. Direct, like the cost that it's more like indirect cost that the hospital bear for the patient, non-medical cost, not the, like we are including salary, drug, everything that the hospital bear, but at the same time, hospital also bear the food they provide to the patient and the other care, palliative care that the hospital provide to the patient. So what about those costs?
Oh, absolutely. I totally understand what you're asking, I believe. So you're saying, okay, well, we have other costs beside, beside the medical costs. So, for example, we're feeding people, and and then we're changing linens, things like that. Yes.
Yeah.
So what we found that was helpful for us was that we include something called a hospital bed day charge. And that's basically all the activities that are used to keep a patient in the hospital other than the actual medical procedures that are being done for them. And so we have that as an other direct cost here, and we say hospital bed day. And then we say what the cost is to the hospital. And so what we've done is we interview the people in the hospital. We say, okay, well, what's included in taking care of a patient? Do you have a hospital bed day charge? And usually they can tell you what that bed day charge is. And that will include all the costs of taking care of the patient other than the medical costs. It will not necessarily include the indirect costs of the building charges and the electric charges and the water charges, things like that. But we're doing what's called an incremental costing in this case. So we're trying to focus on the cost of treating someone who has a particular illness rather than looking at the cost of running a hospital. So use that term hospital bed day and ask them how much they charge for a hospital bed day. Then when you're doing your detailed costings, then you can say when I'm doing a detailed costing of a non-surgical intensive care in the hospital, I ask the clinicians about how many days do you keep the average patient in the hospital? And they may say 3 days or 5 days. So we'll put in 3 days or 5 days as part of that detailed costing. Does that respond to your question?
Yeah, kind of. So now we will include all those costs here in hospital bed day, including the overnight stays as that the hospital took, like usually they ask for.
Yes, that's right. That's right. Yes. Mhm.
Okay, thank you. And I have one more question, sorry.
No, don't please. I'm so glad you're all here.
Yeah.
I'm here for you all. Mhm.
So it's basically going back on your second slide where we were comparing between the age and all other variable. So how about like there must be some difference between the health facility in an urban area and that of the rural area, the way they treat the patient and all other costs. So is there any way we can get that cost as well?
Yes. If you think that it's important and there's going to be significant difference in costs, what I would suggest that you do is you have one file where you're doing a costing for the health facility cost, like a clinic in an urban area. Yeah.
Yeah.
And then I would do another version of the tool where you're focusing on a rural health facility. Yes. And then I would do the costing there. So what we ended up with in Ethiopia and in Ghana, we had two files. One was a costing for a health facility, a health clinic, and a second was a costing for a hospital. So they were two separate files, and we were able to report those separately as well. If you believe there's going to be a significant difference between an urban and a rural clinic, I definitely encourage you to make field visits to each one of those types and to differentiate among the costs. Okay?
Yeah, thank you.
Do you remember I said when I started, I said, we only went to one health facility in Ethiopia, one clinic. And looking, because I think we only had 2 or 3 days, and looking back on it, I really wish that I had gone to an urban and then a rural health facility to see if there was a big difference.
Yeah.
So good on you for doing that.
Thank you, Win.
The other thing just one more thing is to remember is that we are also, if I understand correctly, we're collecting separately the cost of illness to the patient and their caregivers, meaning their family. So we're not collecting that information in this particular costing.
Yeah.
Sure, thanks, Win. Just one quick question. You mentioned that we do not necessarily include the utility cost, like hospital running cost, but if it's needed, I suppose we can add that cost in the current table that we see here, other direct cost prices.
Well, about that, you could theoretically, but I'm not exactly sure how you would go about including that as part of your direct costs. Because this is an incremental costing on direct costs, not on indirect costs.
I mean, there should be a set of assumptions. For example, if we know, for example, electricity, if we know the amount of electricity bills that hospital spends per year, and if we know the number of patients or admissions per year, I guess we can calculate, obviously, electricity cost per person per year. That can be added as a recurrent cost, although it's also dependent upon the assumptions.
Yeah, you absolutely could do that. The question then would come up, is, do you, let's see, is that's an economic cost, right? So then would you annualize it? Would you be doing an annualization of that, of those indirect costs? It comes down to the same question with the equipment, I think. Yeah, is that when you're working on a retrospective costing now, which has so few cases on this, then the question becomes how valid and reliable the information or the data you get is when applying it from retrospective to a cost projection. And that's why I say the solution that we found was using the term hospital bed day, which I think is what's used by WHO in their choice, their 2013 choice thing. So yeah, but that's my take on it.
Sure, great. Thank you. I know we are running a bit late over time, but is there any other question or comment?
Yeah, thank you very much, Lee. This is Folashayo from Nigeria.
Hi, Folashayo.
Thank you, Win, for the brilliant presentation and for this very robust and comprehensive tool for collecting the data. I'm just going to quickly chip in here and there, a follow up to what the last two speakers just said. I believe that we can, in as much as we have looked at the direct costs or the medical costs. If it is adaptable at this point, I think we should look at more of a little more about or around overhead costs. And I believe that was what Lee was trying to say. Overhead costs would, of course, include the bed space, the utilities, and a number of other things within the facilities, either from the clinic or from the hospital. So from the response of Wayne, he was talking about trying to capture all of that using the bed space, the bed fee, which I think is just one of the components of the overhead costs, especially in our setting in Africa, in Nigeria. So if this can be factored in at this point, I think it's going to be very helpful. Thank you very much.
Thank you for that feedback. I guess Sol and Jungsuk, let's discuss that offline, okay, to see how we can respond to that to make sure that everyone's getting the information they want to get. Okay.
Sure, sounds good. Any other questions? Okay. If not, I guess we can end our.
Sorry, I have one question. Enoch from Burkina Faso.
Sure, go ahead, Enoch.
Yeah, the data present in this example covered what period? And for the collection of the data in our different sites, will we follow a data collection schedule? I don't know if you understand my question.
Enoch, I'm sorry. Your voice was not clear.
Okay.
Okay.
I said that the data that present in this example covered what period? And for the collection of the data in our different sites, we follow a data collection schedule?
Oh, interview schedule, you mean?
Yeah, and yes.
So for when you utilize this tool, we do not follow any interview schedules. For example, So when we use this tool, let's say there is an INTS confirmed patient, we just collect all the treatment related costs from the health facility side. So if this patient was hospitalized for example, for 30 days, then in our questionnaire, out-of-pocket questionnaire, we will conduct 3 or 4 different interviews. But when we utilize this tool, we just capture all the costs incurred during the entire month at once. Does it make sense?
Okay. Yeah.
Okay, thank you.
Okay.
I wish I could be out there with all of you each time.
Same here. Okay, if there are no more questions, we can end the session today. For INTS studies, the countries from Ghana, Burkina Faso, and Malawi, we are going to have this monthly meeting soon. I forgot the date, so I will mention it once more. But since we completed our training session for health facility costing, I would like to ask you to go ahead and collect this information from our health facilities, especially given the tight timeline. We are still waiting for this timeline extension, but not sure if it's going to happen or not. So it would be great if we can start collecting this information from now. Inoue and Francis, that would be nice. I will highlight this once again during our monthly meeting.
And Jung-Suk, I've put my email address in the chat box. So if anyone wants to follow up with me, please feel free to send me an email or send a request if you like for a Zoom meeting. It has to be a Zoom meeting, not a team meeting, just because of the way that Zoom works better for me. And I can, if you want me to set it up, just let me know.
Sure, thanks a lot, Win.
I want to say thank you to all of you for the work that you're doing in very difficult circumstances. I've lived in Liberia, I've lived in Zambia, I've lived in Ghana. So I understand what you're doing and the sacrifices you're making. And I really do appreciate it. And it's an honor to be able to do a little bit of help in working with you.
Great, thank you very much, Win. As you can see the chat box, many people are appreciating your presentation today and also videos. So once again, those who have participated in the session today, please take a look at the videos that Win uploaded. Much more details there in terms of data entry. And feel free to drop a line if you have any questions. Whenever you write an email, please copy one of our PR members as well, so that we can also follow up all together. Okay, then I think we can end our session today. And Kofi, if you don't mind, would you could you just stay one more minute, just for a quick discussion?
I'll say good morning, good afternoon, and good evening.
Okay, thank you very much.
Thank you. Bye.
Bye.
Kofi, can you stay one more minute?